Okay, the first one's easy. So the question might be a picture or a description. So what are these two abnormal positioning again, and what score do they have on the Glasgow Coma Scale? So this one is called what? And this one? Okay, and what's their respective scores?
What is that plus called for?
This is 3. This is 2. Yeah.
Oh, yeah.
2. Yeah, so that indicates since 2 is since 2 is lower, that means it has a poorer prognosis compared to the corticate. So you've probably seen them in either nursing homes, in long-term care, when you've seen those patients that are like this, right? On a vent, okay, because they're long-term brain injury patients. So those are what you see. You won't see a person who is in the cerebret in long-term care. Did you see that? Did you notice that? You won't see them. Why won't you see the cerebret people in long-term care? Why do you think that? Yeah, we see a lot of people in the corticate in long-term care because in the cerebral people they usually die because that's in severe head injury. They don't last long. Next is recognizing and treating ICP. So that brings you to what are the signs and symptoms of increased ICP. So that's recognizing, and then of course action. So this could be one same question. So the scenario may start with the manifestation. So it'll describe how the patient is looking, and then the question might be, what do you do? So therefore, recognizing what it is, and then choosing the appropriate intervention. So where do we find this information? Which topic? Where did we see increased ICP? Head injury. Was it exclusive in head injury, or did we also see them? We also saw them in stroke. Okay. So in the case of Joyce mentioned hemorrhagic stroke, but could you also see it in ischemic stroke? Yes, because why? Why is there increased ICP in ischemic stroke? Okay, because regardless of the cause of the stroke, the fact remains that something died, correct? Yeah, so brain tissue died. And then, of course, whenever there's something dead in your body, what will always form around the dead, the surrounding tissues? No, well, not yet. Not yet. So at the moment of, okay, there's always inflammation. Okay, so whenever there's injury or death too, and it doesn't matter where, it could also happen in a heart attack. Remember pericarditis? Why did a patient after an MI develop pericarditis? Because did cardiac tissue die? Yes, the heart muscles died. So therefore, there will always be inflammation. So that's why it can lead to pericarditis. Any question on number 2? All right, so number 3. What is the most commonly used ICP monitoring equipment? Because remember, we cannot measure ICP, intracranial pressure, without an instrument. There has to be a device that you intraventricular catheter. There are, of course, many mentioned by the textbook. There's bolts, screws, but the most commonly used one is the intraventricular catheter. Why? Why do doctors choose that? Yeah, all of the other equipment like bolts, screws can also measure the pressure. But why the IVC catheter? Well, this is the most invasive because you drill the hole and then you put a catheter into the ventricle. So what is the other benefit of this device?
Oh, it can also release.
Okay, because they have the ability to drain the CSF and thus lower ICP, but not much, but better than nothing, right? Yeah.
Just to ask, that's the one where they always have to make sure it's level with the patient.
Correct. So, did I discuss that in class? No? Okay, just so you have an idea. So an IBC, you saw it in Delview? Okay, yeah, okay, very good. So it's actually looking primitive because all you do is, you know what a level is, right?
Yeah.
No, that thing, the instrument that has a water in it, there's a water air bubble.
Yeah.
Same exact thing. So you want to make sure it's level because otherwise, if it's not level, the reading would be inaccurate. So we need the patient and the transducer at level. So you adjust the patient's head of the bed, because the transducer is on a pole, okay, and then you make sure it's level because otherwise the reading would be inaccurate. And remember, when we calculate the CPP, does the patient's therapy depend on an accurate calculation of CPP? Yes, because that's how we determine whether or not the patient is brain dead or if our interventions are working, correct? So because it's invasive, so what is your nursing responsibility therefore? Okay, so you have any questions about how to check for infection? I mean, regardless of where the infection is, you should be able to recognize, right? So let's review. So how do you, Tyree, how do you know if the IVC insertion site is infected?
Would have, inflammation, like it would be possibly leaking.
There's be some discharge, right? And what would that discharge look like?
Like it would more look like whitish.
Okay, you know what pus looks like, right? Okay.
Hairline.
And so do we want to see that?
No.
So how do we prevent it therefore? Okay, so because it's an area wherein, yes, we clip the hair, but does the hair stay short?
No.
It will grow. So always maintain the site. So if you need to trim it, and then make sure you have there will be routine round the clock bacitracin order. Hey, what is bacitracin? Antibiotic one. Okay, let's go to MS now. So these are some of the drugs used, not all exclusive, but these are the ones at least on your exam. So what are the purposes of each one? So interferons, we have beta and alpha interferons. We got Copaxone, which is the injectable. Fingolimod is the PO. Then we have,
You said Copaxone?
yeah, Copaxone is a pre-filled syringe. This looks like you've seen Lovenox.
Yeah.
Okay, so it looks like Lovenox, the same package, same pre-filled syringe. So the patient is taught to self-administer this because this is their daily daily medication. So these are the immunomodulators. There is the PO here, that's fingolimod, or Gilenya, that's PO. And what is baclofen again? Okay, so we saw baclofen. Was it exclusively used in multiple sclerosis? Where else did we see baclofen? Parkinson's? Huntington's? ALS? Yeah, okay, so these are commonly used. What about steroids? When are steroids used in multiple sclerosis? Only during exacerbation. So we use high dose steroids for flare-ups, for exacerbations. So that takes us here. So this is the same similar question. So when are steroids used again? Only during exacerbations. And regarding these questions on nursing responsibilities, so what is the most frequent cause of an MS flare-up? Okay, and is stress specific? No, very broad, very unique to the person, right? So it could be illness. So Sonia mentioned illness, especially if you're septic. What else? What about pregnancy?
Extreme.
Okay. Extremes of temperature. So too hot, too cold can trigger an exacerbation.
So would the nursing responsibilities be to educate the patient on how to manage stress or just take stressful environments, take the patient away from stressful environments?
Well, it's easier said than done, right? But with in MS, so what would you pick for the patient to do? Because you know that exacerbations is very unique to the person, but can we absolutely prevent an exacerbation?
No.
So therefore, let's say you said it's infection. So therefore, what would be your most important teaching?
Facial washing.
Okay, so hand washing, okay, basic things like that. Avoiding illness, staying away from sick people. All right. This one is could be a patient education. Okay, you're explaining something to the patient or the family member. What's the difference between Parkinson's, MS, and also ALS? So if you put side by side, how do you distinguish one from the other? Was there a table for this?
It was in the
I
paragraph.
think there.
I think
Let's
there was
see.
only one of them.
One of the was in the
Or
I could read it.
I think I remember something.
Yes.
Drugs used for Parkinson's. What was the first group that the patient is put on? Dopamine agonists, right? So we've got dopamine agonists. There are dopamine adrenergists. Okay.
That's the cinema.
Yeah. So levodopa, carbidopa, and then you have the anticholinergics, which is benztropine, and then we have um the one ropinirole, the one for like restless legs, okay, amantadine, the antiviral, and then we've got the was apomorphine included? Oh yeah, MAOIs. Okay. Among all these, please make sure at least I know for sure Cinemet or levodopa carbidopa is on the exam because since it's the most commonly used drug. So make sure you know how that drug works.
And just as a refresher, the levodopa is the dopamine and the cinematic stops it from being metabolized.
No, the drug Cinemet is
carbidopa
is the brand name, right? Yeah, carbidopa would prevent it from being destroyed. Remember when the drug crosses the blood-brain barrier? Yeah, that's the problem because during crossover, most of the levodopa will be destroyed. So therefore, if you add carbidopa to it, it leaves most of the levodopa intact as it crosses. Yeah, what makes the drug work better. Here teaching for all three, Parkinson's, teaching for Parkinson's patients, MS patients, ALS patients, because these patients live at home. A majority of them are at home. They're not really institutionalized. Even ALS patients, because of the poor prognosis, they prefer to stay at home. They're probably on hospice care, but they're not in a facility, most of them. This is a typo, okay? I don't know why that D is there. Yeah, it's a typo. Spinal cord injury assessments by level. Remember, we found a table for that. Yeah, so table, focus on what can they do, because that's your assessment by injury level. Priority management would be, of course, the emergency management. Initial would be ABC, correct? ABC and then followed by stabilization of the neck. So you put in a rigid collar, then you look for other injuries. So it was a paragraph for emergency management. Both brain injury and spinal cord injury had primary and secondary injuries, correct?
Correct.
So what are the primary injuries again?
That's a result of what happened.
Okay, so these are the laceration, the contusion, the bruising, okay, the bleeding as a direct result of the trauma. And then the secondary injuries are now the result of chemical, physiologic processes that occur after the primary injury. So remember, there are up to 6 of them. So we start from hydrocephalus to increased ICP. What else? Hemorrhage, edema, seizures.
Can you just start that from the beginning again? I'm sorry.
Even better, let's go to here. Okay, so here are the secondary injuries. So they are a result of so these are basically consequences of the primary injury. So the patient's problem does not stop with the primary injury. There are up to 6 that will follow. Example, increased ICP brought about by bleeding, intracerebral bleeding, the edema, the intracranial hypertension, which is increased ICP, hyperemia, or you can do hypothermia there, seizures, and vasospasms. And it'll be the same when you go to spinal cord injury, because it's an extension of the CNS. What's the difference between spinal and neurogenic shock?
So neurogenic shock is neurogenic shock has to do with it has to do with the whole autonomic system, autonomic nervous system, where the nerve.
So there's vasodilation, right? Yeah.
And then the spinal shock is the result of an injury to the spinal cord. They can get better, but depends on what the
level of the injury is.
that.
All right. So just know that they're not the same. Both are called shock, but spinal shock has nothing to do with blood pressure. What happens to heart rate in neurogenic shock? Bradycardia. Belinda, you had a question?
Well, question, we were kind of having a debate about this yesterday. In the book, it does say something about blood pressure, or spinal shock.
Did it say the patient's blood pressure will drop below 90? In spinal shock?
Is it high flow? It's in one paragraph, it doesn't specify which one. Does it
It's for- it's
specify
for
which
neuro-
one?
It's for spinal cord shock.
The hypotension?
Yeah,
Yes.
It says no outlet and.
yeah, remember the page?
The spinal shock has limit.
We were, okay. And then management, of course, you know how to manage neurogenic shock. Let's review what are your first actions? You recognize neurogenic shock, the blood pressure is low, heart rate's below 60. What's your first action? Is this an emergency? This is shock. So it's always every life-threatening emergency, you rapid response. Okay, so rapid response first, because this is emergency. Okay, so rapid response, get the emergency staff rolling. So you activated the emergency response, and then you proceed. Yeah, you can proceed with oxygen, and then prepare to give. What will the team ask you to do? You will give lots of fluids. Okay, fluids, and then atropine for the bradycardia, and then usually the fluids will not be enough. So okay, vasopressors to promote vasoconstriction. All right. This one's the same as this one. So that means you have two questions on the spinal cord.
I'm sorry, what was the management of spinal shock?
Rapid response.
No, not spinal shock, that neurogenic shock. Yeah,
So.
because spinal shock is not an emergency.
Okay.
Yeah, so that's long term. Okay, so that could last 2 days, or it could last several weeks, or it could be months. Okay, nothing. That's what I wanted to make sure you understand spinal shock. It is not the same. This is the true emergency. Neurogenic shock is the true medical emergency. Spinal shock is not an emergency. Yes.
So the neurogenic shock for management, which one would first choice for rapid response?
Yeah, just like any other life-threatening emergency, right? You call rapid response. With the, let's say, what are others? Remember how you manage compartment syndrome? What was your first action also? No, again, what's the first action? Call, okay? Call rapid. These are, again, life-threatening things, okay? Remember, if it's life-threatening, first action will always be call, yeah.
So you call the team, when you
Yeah.
call the doctor, then you receive oxygen and fluids, then you give oxygen.
Yeah, because we need the team's orders for those anyway. There's not like a standing, so that's why you need rapid response. And then once the doctors are there, then they'll give you the verbal orders. Right. So let's review. This is for the NCLEX already. So for the compartment syndrome, since I mentioned it, what was your first action again? Because what did you see in compartment syndrome? We call them the
Varicose, yes. Varicose, yes. 5 sheep. No.
6 Ps. Okay. So you saw a few of the 6 Ps, doesn't have to be all 6. And then what you recognize it, what's your first action? Call the doctor. And then while waiting, then the book says, then you remove the dressings. Okay, things you can do that the doctors will tell you to do anyway.
But the physician.
Yeah, because they have to, you need an order. But things you can take off without instruments like the bandages, yeah, you can do that. You can start doing that.
And for the neurogenic, you're not gonna ask us what kind of things you're gonna get.
Well, what fluids? We finished module 1, shock already. So what's the, crystalloid, so saline or LR. So there was an entire chart, right, for the halo vest. Okay. What are the 5 interventions when you get an order for spinal precautions? One is Are they allowed out of bed? Bed rest. Okay. Number two, spinal precautions. Because this one is an entire, the halo vest is an entire chart. So spinal precautions in general. So what do you do when you get an order for spinal precautions? Okay, so neck should be in a neutral position, so no flexion, no extension. Okay, neutral. Is that number two? Yeah, so bed rest, spinal immobilization, which is the neck collar, and then you said what? Yeah, neutral position, and then when we clean doo-doo or when we because they are at risk for pressure ulcer as well. So we do log rolling. Okay, that's 4. And then 5, if we have to, let's say there is a respiratory issue, there's a ventilation issue, what can you do?
Elevate.
You have to elevate. So can we elevate the head of the bed?
Yes.
But it said no flexion, no extension. Okay, reverse Trendelenburg. Are we clear? All right.
Wait.
That's fine, you said.
Yeah, you can. You can. The spinal precaution means they have to be flat. Okay. Reverse Trendelenburg. So this is Trendelenburg, right? So my head is down, correct? So now we can do reverse. We can head is up, but the body is still in alignment. Okay. No, there was 5 already. So bed rest, neck.
Oh, so that's separate, and then you can neutral, then no flexion, no extension?
Yeah.
That's separate?
Well, the neck immobilization is separate. No, you put on rigid neck collar. If you need to elevate the head of the bed.
There's no, I know. Well, I guess it depends on the level. Yes.
What do you mean? I know.
For like, depending on the level. they-
We typically worry about INO. So this is in general. Okay, so INO is usually a concern when we have heart, kidney issues. Any perfusion issues. So we worry about INO because the patient's urine output is crucial in evaluating your care. You understand?
Yeah, I know.
Bowel and bladder management. Since these patients, can they pee and have number 2 independently?
No.
Okay, so there is no bladder innervation. Remember, their paraplegics can't do that. Okay, the sphincter doesn't work. Okay, so therefore you have to straight can. Okay. And for the bladder, the bowel. Well, we don't promote that, but you do a bowel regimen, correct? So for high fiber diet, the stool softeners, etc.
Professor,
Yep.
question. This is for yesterday too. Is it a straight count or indwelling count?
Because with indwelling, remember what's the risk for
Okay.
UTI?
So, but the book was saying for the first, you would put a catheter in, but discontinue from discontinuation, so it's no indwelling at all.
Well, you're referring to, let's say, under emergency management. That would be here, which is 24, 48 hours. But this is now at home. This is now perpetual bowel and bladder management. Meaning client teaching, because they have to be discharged, correct? So how are they gonna manage daily bowel and bladder?
So to clarify, in an emergency setting in a hospital, it's indwelling, but once they're home, it's straight.
Again, the reason for that is what? Why do we, okay. So only during the first 24, 48, right? Right. So with COTI, what is our standard again? So this is not just for spinal cord injury patients. So what's the general for everybody in the hospital that gets an indwelling catheter,
Yes, get rid of it as soon as possible,
which is how long?
as soon as possible.
There's a maximum. Yeah, because in the UTI chapter, what did the risk say? When does the patient have a likelihood of developing a UTI from a catheter? Over 2 days, which is 48 hours. So therefore, we discontinue the Foley
Unless it's.
in less than 48 hours. What about the sexual activity? So what do you teach the patients?
Being still get
That's it, still have
aroused
sex, but
from,
individuation, they have to shake well before you
But they,
can ejaculate with urine, but it's clear, it's not.
Okay, all right. As long as there's no UTI. So yes, that's true. Urine is sterile.
Yes.
pushing,
And
No,
then
what?
take Viagra,
pushing or pulling.
and then take Viagra.
But they can still have their sex, but there's no bigger pushing or pulling. Someone else
They have a spinal cord injury, so they already can.
for sexual activity.
so they can.
I don't understand.
I think basically, what you said, if you're like pushing and pulling while doing.
No, that part is no longer a concern actually, because this is, of course, you're not having sex in the hospital, are you? No, this is now at home, so that's not a concern anymore.
Okay, okay.
Yeah. I'm just clarifying, okay, that's not a, yeah, because I mean, this doesn't happen in the hospital. Right?
So,
Yes,
oh no, I was just gonna ask, in autonomic, let's say, I know we're gonna get to that, but, is that an emergency where it'd be an indwelling cath, or is that straight cath as well?
depends on the scenario. In my experience, I chose a Foley because the doctor's just gonna say, okay, just straight cath, all I'll do is take it out. But if the doctor had, because you remember in the example I gave, the patient was in HHS, right? So he still needed fluids. Does that make sense?
Yeah.
I mean,
So
it's
if you
likely
get the
gonna,
fluids, then they're
correct,
urine.
yeah.
Okay.
So we expected the patient to still have increased urine output. That's why I chose the Foley, because the fluids are still running. So of course, the urine output will
So
be
in a tested question, it depends on how the question is asked, I guess.
correct.
Okay.
Yeah, but I mean, the doctor, I mean, the NCLEX, I don't think they'll make you choose between a straight cath and a Foley. I don't think so. Because the objective is just to empty the bladder, because it's the most frequent trigger.
Are you gonna mention the medication that's mentioned that they take or no?
Which medications?
The muscle relaxants.
Yes,
It
but
was like-
they're right. So because the paraplegics can still have muscle spasms. Yeah, and that was mentioned in the nursing care as well. Spasticity. Anglada? Okay, right here. So patients with tetraplegia or paraplegia have varying degrees of loss of motory. So basically, keep in mind that sexual activity is still possible in these patients, and that, remember I gave an example last week or 2 weeks ago that if you're paraplegic, can you feel anything below your waist? So is it possible that you're sitting on your balls?
Yeah.
Yes.
Or let's say you have any pressure ulcers. Yes, are these painful?
Yeah.
Very painful, but can they feel it though?
No.
But because these are painful stimuli, which trigger sympathetic response, can they trigger autonomic dysreflexion?
Yes.
Okay, so what are the top two though?
bowel and.
Distended bladder and a,
Bowel.
okay, bowel impaction, okay. Okay, so here is your, to complete the sexual needs of to meet the patient's sexual needs. So here that you can encourage them to just adjust to the loss of sensory motor function, so they can explore other ways of sexual expression if the couple chooses to do that way. Here there are examples, but here we have drugs. You're familiar with Viagra, right? So they work as long as they're prescribed, of course. Okay, and there are other ways, like I said, of expressing or meeting their sexual needs. So for autonomic dysreflexia, let's go to the triggers again. Signs and symptoms and management. That should cover the entire line. So triggers, signs and symptoms, management, and prevention. So here are your signs and symptoms. How do you know? Patient will have, okay, the first complaint will be a severe pounding headache. And then this is true for all spinal cord injury patients, okay? Whether tetraplegic, meaning all paralyzed from the shoulder down, or paraplegics, paralyzed from the waist down. So when they have these severe pounding headache, hypertension, diaphoresis above the injury, nausea, nasal congestion, and of course the bradycardia. These are your manifestations of autonomic dysreflexia. What again is the most common trigger? No, the trigger. Okay, so therefore, you will always check what first? Always check the bladder first. But in addition to a full bladder, this also be triggered by, so besides the bladder, what else?
Constipation.
Okay, the bowel, or remember pressure ulcers? Okay, or any injury. How many times you've been in clinical for a while? How many times have you seen leftover stuff under the patient, like a bottle cap, the covers of the needles, some syringes sometimes, or any other plastic that people drop, and then the patient's been laying on it for hours. Okay, especially for these patients, because what's the problem with these patients? Tetraplegics and paraplegics. They can't feel anything. Okay, so especially prone to injury. And interventions. So the triggers. So we look at the triggers, signs and symptoms, and then management. So here's your management. What's the first action?
Sit them up in our arms.
Okay, so after sitting them up, what's the next action?
Then you inspect for what's causing the stimuli.
Okay. All righty. And look for the others. But of course, what's missing here? What's the very first action? Because it's an emergency, because this is an emergency. So okay. Call rapid response, and then start with the sitting the patient up, and then look for your triggers. And here's the halo vest we had earlier. On a break?